Examination of an acute abdomen. Acute abdomen means the patient complains of an acute of abdominal pain that may occur suddenly or gradually over a period of several hours and presents a symptom complex which suggests a disease that possibly threatens life and demands an immediate or urgent diagnosis for early treatment. A careful history should be taken indicating the symptoms of patient and careful examination to find out the physical signs and their interpretations which are of a high significance to come to a diagnosis in these cases. It goes without saying that how important it is to make the diagnosis as early as possible in these conditions. Delay will definitely worsen the condition of the patient and may lead to fatal outcome. History. First point is age. A few acute abdominal conditions are particularly seen at a definite age group. In newborns, intestinal obstructions due to intestinal atresia and stenosis, meconium ileus, meconium peritonitis, imperforate anus, and annular pancreas are commonly seen. In infants, midgut volvulus, intussusception, and mecal diverticulitis are common. In children, appendicitis, non-specific mesenteric lymphadenitis, primary pneumococcal or streptococcal pneumonitis, and roundworm intestinal infections are commonly come across. In young adults, appendicitis and Meckel's diverticulitis are common. In adults, perforation of the peptic ulcer, acute cholecystitis, and acute peritonitis are more common. In elderly, sigmoid volvulus, intestinal obstruction from malignant growth, diverticulitis, and mesenteric occlusive disease are commonly seen. Sex. Ruptured ectopic gestation, twisted ovarian cysts, acute salpingitis are obviously the diseases of women, but a few acute abdominal conditions are particularly more often seen in females than males. These are acute cholecystitis, acute appendicitis, primary peritonitis, etc., whereas perforation of the peptic ulcer, pancreatitis, volvulus intussusception, etc. are more common in men. Occupation. Painters may have recurrent abdominal pain due to lead poisoning. Similar workers in arsenic industries may suffer from similar disease. Residence. Peptic perforation is more common in northern India and in southern India due to their habit of taking very spicy food. Acute cholecystitis is more common in eastern India and southern India. Amoebic typhlitis is only seen in tropical countries. Pancreatitis is more common in western countries due to their habit of consuming alcohol. Appendicitis is more common in western countries, maybe due to their habit of taking low residual diet. Social status. Appendicitis more common in high income group. Probably they tend to take more protein as the main dish and ignore vegetables. Peptic perforation is more common in low income group as they tend to ignore peptic ulcer disease at an early stage. Chief complaints. Pain. Time of onset. The pain of acute appendicitis starts early in the morning, whereas sudden pain due to perforation of a peptic ulcer usually takes place in the afternoon after the lunch break, but the patient is often brought to the hospital at night time. Mode of onset. This is sudden in perforation, colic, torsion, volvulus, etc. In acute intestinal obstruction, the pain may not be severe at the onset, but gradually it increases in the intensity. In acute appendicitis, the pain becomes boring in the beginning and suddenly becomes acute in cases of acute obstructive appendicitis, which often wakes up the patient in the early morning. Acute abdomen is sometimes precipitated by administration of purgatives, example acute appendicitis, by straining, example perforation, or by solving urinary colic. How long is the history of present complaint of pain? Similar type of pain with varying intensity appearing on and off for the last few years is the feature of appendicitis, cholecystitis, etc. In peptic ulcer, periodicity is noted before perforation. Site of pain. It usually coincides with the position of the affected organ. The patient is asked to indicate the site of pain with the tip of the finger, which is known as pointing test. If the pain is diffuse, the patient will obviously use his whole hand instead of one finger to locate its site. If the pain is at the flank, renal origin is considered. When it is below the right costal margin, liver or gallbladder disease is suspected. If it is in the epigastric region, peptic ulcer, perforation, acute pancreatitis, etc. are considered. Shifting pain. This is characteristically seen in acute appendicitis. The pain is initially felt around the umbilicus but later on shift to the right iliac fossa with the onset of the parietal peritonitis. Radiation of the pain. In spreading peritonitis, the pain is first complained of at the region of the affected organ, but it soon spreads all over the abdomen. In case of peptic ulcer perforation, the pain is at first felt at the right hypochondriac region, but soon it is radiated towards the right iliac fossa as the gastric content gravitates down the right paragolic gutter. At this time, this condition mimics acute appendicitis. When the patient complains of a radiating pain towards the left iliac fossa while he is suffering from acute appendicitis, the condition is one of the spreading peritonitis. Referred pain. The pain is said to be referred when it is felt at some other regions having the same segmental innervation as the site of the lesion. The lesion of the stomach, duodenum, and jejunum T5 to 8, the pain is felt in the epigastrium. In affections of the ileum and appendix, that is T9 and 10, around the umbilicus, whereas in case of colon, T11, 12, L1 and L2 in the hypogastrium. The diaphragm is supplied by the phrenic nerves C3, C4 and C5, of which the main supply comes from the fourth. The cutaneous nerve from the same segments are concerned in supplying the skin over the shoulder, as also the upper part of the front of the chest through supraclavicular nerves C3 and C4. Any irritation on the undersurface of the diaphragm, either by gastric contents or blood or bile after operation on the biliary tract, or inflammatory exudates, may give rise to referred pain to the corresponding shoulder. In suspected cases, that the foot end of the bed may be raised by about 18 inches to allow the exudate to gravitate down towards the undersurface of the diaphragm, which will obviously initiate pain on the corresponding shoulder. In renal colic, the pain is referred from the loin to the groin, testis, and inner surface of the thigh. That is distribution of the genitofemoral nerve, which is L1 and L2 segment. The same segment supplies the ureter also. In biliary colic, the pain radiates from the right hypochondrium to the inferior angle of the right scapula, since the gallbladder is supplied by the 8th, 7th to 9th thoracic segment. In passing, it must be emphasized that segmental nerve supply, as has been referred to in this section, is the sympathetic supply of the viscus. Of course, the same viscus also receives the parasympathetic supply mostly from the vagus, the sole exception being the hindgut and the bladder, which receives the sacral sympathetic supply. Similarly, irritation of the parietal pleura, as may occur in the pleurisy, hemothorax or pneumothorax, may initiate referred pain to the abdominal wall, as they mimic the acute abdominal conditions. Coming to figure 33.2, here a diagrammatic representation of the various types of pain seen in acute abdomen. In perforation of the peptic ulcer, pain is infrequently referred to the right shoulder and migrates along the right paracolic gutter towards the right iliac fossa. Pain originating in the gallbladder may radiate to the back just below the inferior angle of the scapula and even to the right shoulder. Splenic pain is referred to the left shoulder, which is known as the Carr's sign. In appendicitis, the pain occurs primarily at the umbilicus or epigastric region and shifts subsequently to the right iliac fossa. Renal colic is referred from the loin to the groin, testis, and inner side of the thigh. Bilateral pain and tenderness over the hypogastrium, shown by crisscross, characterize acute salpingitis. Characteristics of pain. First is a colicky pain. It is sharp, intermittent gripping pain which comes on suddenly and disappears suddenly. It indicates obstruction to a hollow organ, either bowel obstruction, intestinal colic, obstruction of the common bile duct with a stone, biliary colic, or obstruction of the renal pelvis or ureter with a stone, renal or uretary colic. Constant burning pain is a feature of peritonitis and is often seen in perforated peptic ulcer. Severe agonizing pain is very much characteristic of acute pancreatitis or of torsion. Throbbing pain is suggestive of inflammation, hepatitis, and cholecystitis. Change in the characteristic of the pain is sometimes noticed. Colicky pain in acute intestinal obstruction may change to constant burning type, which indicates strangulation. Diminution of the pain is not always a very happy symptom. In acute appendicitis, it may indicate perforation of an obstructive gangrenous appendix. In second stage, the stage of irritation of peptic perforation, pain diminishes in intensity, although the disease is continuing. This is due to the fact that peritoneal exudate dilutes the irritant gastric content. Effect of pressure on pain. In colics, pressure gives relief, but in inflammatory condition, it aggravates the pain. Relation of the pain to jolting, walking, respiration, and micturition. In amoebic hepatitis, cholecystitis, and appendicitis, the pain aggravates during walking and jolting. Ureteric colic sometimes get worse by jolting. In diaphragmatic pleurisy, the pain is aggravated during sleep, inspiration, and coughing. Pain during the act of micturition or strangury is frequently met with the ureteric colic, pelvic appendicitis, or even pelvic abscess. What makes the pain better or worse? In case of peritonitis, pain is slightly relieved if the patient lies still. If he rolls about, the pain becomes worse. In case of pain due to diaphragmatic irritation, either due to inflammatory exudate or due to blood from the injury to the liver or spleen, deep inspiration will aggravate the pain. In case of cholecystitis, fatty food will aggravate the pain, whereas fat-free diet will give some relief. In case of peptic ulcer perforation, alkali will make the pain better, whereas alcohol, spicy food, or drugs like aspirin will aggravate the pain. In case of hiatus hernia, the reflux esophagitis stooping will make the pain worse. How is the pain relieved? Vomiting sometimes relieves the pain in peptic ulcer. In colics, vomiting temporarily relieves the pain, which reappears immediately. In acute pancreatitis, the pain is relieved to a certain extent by shifting up from the recumbent position. Application of local pressure relieves the colicky pain, biliary, ureteric, or intestinal. Vomiting. Character of diet. The vomiting may be projectile, that is involuntary, forceful ejection of a large quantity of vomitus in high intestinal obstruction, toxic enteritis, etc. In case of peptic ulcer perforation or general peritonitis, the vomiting is quite regurgitation of mouthfuls. Vomitus in intestinal obstruction. At first, the stomach content, next the duodenal contents, bilious, and lastly the intestinal content, feculent, are voided. True fecal vomiting is not common. It is also seen in gastrocolic fistula. In case of biliary colic, the vomiting is usually bilious. In case of peptic ulcer, vomitus is nothing but gastric contents. In late cases of peritonitis, the vomiting becomes dark brown feculent being mixed with the altered blood. This type of vomiting is also seen in uremia. Frequency and quantity. Vomiting is constant, frequent, and profuse in acute intestinal obstruction and acute pancreatitis. In peptic ulcer, vomiting is periodical. In perforation of the peptic ulcer, vomiting is not a diagnostic feature. It may be once or twice during the first stage. It is more or less absent in second stage and may reappear in last stage with the characteristic vomiting of diffuse peritonitis. Similarly, in acute appendicitis, it may or may not be present, but nausea is more often complained of. Both nausea and vomiting are characteristic complaints in pre or post-ileal appendicitis. Its relationship with pain. Pain precedes vomiting in acute appendicitis, acute pancreatitis, peptic ulcer, biliary and renal colics. In high intestinal obstruction, vomiting appears almost simultaneously with the pain. In obstruction of the lower end of the ileum, vomiting may not occur in the beginning but follows after a few hours. In large bowel obstruction, vomiting is absent or is a late feature. Vomiting relieves pain in case of peptic ulcer, but in colics it relieves pain temporarily so that it reappears immediately. Bowel health. Absolute constipation, that is arrest of both feces and flatus, is the usual accompaniment of the intestinal obstruction and peritonitis. A history of one motion in the beginning of intestinal obstruction is not unusual. In acute appendicitis, history of constipation is often received. In pelvic appendicitis or pelvic abscesses, irritation of the rectum may lead to tenesmus, that is ineffectual straining or straining at stool with passage of the mucus and blood. In children, features of intestinal obstruction accompanied by passage of mucus or blood per annum is suggestive of acute intussusception. In mesenteric thrombosis, blood and putrid stool may be noticed. Diarrhea occurs in acute ulcerative colitis, regional enteritis, and acute enteritis. Micturition. Strangberry, that is painful and frequent attempts at micturition, passing only a small quantity each time, is often come across in cases of stone impacted in the lower end of the ureter and stone in the bladder. In inflammatory conditions of the neighborhood of the bladder and ureter, such as the retrocecal appendicitis, pelvic appendicitis, and pelvic peritonitis, they may give rise to same condition. In even retrocecal appendicitis lying in very close proximity to the ureter may lead to hematuria, which may mislead the clinician. Personal history. In women, the menstrual history is a very important and should never be missed. A history of missed period is often present in rupture of the ectopic gestation. If a patient presents with symptoms very much similar to acute appendicitis in the middle of her menstrual period, one should suspect rupture follicle uterine cyst. Smoking and alcohol habits should always be inquired into. Past history. In perforation of the peptic ulcer, previous history of ulcer pain may be elicited. Even there may be a history of hematemesis and melena. In suspected cases of acute appendicitis, biliary and renal colics, history of previous attacks may be presented which the patient may consider to bear no relation with the present illness. In intestinal obstruction, one may get history of previous abdominal operation. Acute cholecystitis, there may be past history of biliary colic, high rise of temperature, and jaundice.